All right, so welcome to the morning conference. I'm going to follow up on Dr. Stevens' lecture from a couple weeks ago on arthritis and really focus this morning on just showing a bunch of cases. It may not be terribly interactive, but I want to just go through a fairly large number of plain film cases of arthritis. I think this is one of the most challenging areas in MSK, and we have a reasonable volume of it that comes through here, but kind of the key take-home point is that it takes quite a bit of careful analysis and a good background on the clinical syndromes of arthritis in order to do a good job with the radiology. I just have really one text slide, then we'll get into the cases. The important thing to remember is that we tend to feel like we work in a vacuum, but we don't really, and we don't have great clinical information a lot of the time, but the diagnosis of different arthropathies is really a combination of the clinical features and the radiographic features. And a good clinician can really make a pretty good diagnosis of an arthropathy based on the things listed here, the patient demographics, what their history and symptoms are, what their risk factors are, things like, are they patient diabetic, are they immunocompromised, and do they have things like inflammation, fever, pain, and things like that. The overall distribution of the arthropathy or symptoms is really important too. So patient coming in with an acute monoarticular arthritis or joint swelling is different than somebody that has a symmetric distribution of kind of gradual onset of swelling and pain and so on. And there might be ancillary findings too, like patient may have a rash that may make you think of psoriatic arthritis, or they may have iritis, inflammation of the iris and conjunctiva. They may have discharge. They might have an obvious infection in a joint, or they may have some other kind of nasty kind of genitourinary discharge, which might point you to a gonococcal arthritis. And they also have good lab tests, right? So basic things like sed rate, white count, serum markers, and many times they'll tap the joint if it looks like an effusion and send that for analysis for culture or for crystals. So there's a huge background that goes on maybe before we see the patients. And then we see the images and this selection process, whether the clinician actually gets images or not. And I would actually say that at Stanford, our practice in immunology is they're not really that imaging intensive. A lot of the diagnoses are made clinically and monitored clinically with just limited imaging. But when we do image, the things we need to think about are what's the distribution of the arthritis in the skeleton, both globally, like is it monoarticular, polyarticular, is it symmetric, asymmetric, and then within a given location, like the hands, we'll look at this. What's the local distribution? Does it spare certain joints? Does it affect joints specifically or symmetrically? And the other things that Dr. Stevens touched on, soft tissue swelling, are there joint effusions that we can detect? A real important thing is, what do the cartilage spaces look like, the space between the bones, because that lets us infer whether the cartilage is normal thickness or not. The presence or absence of erosions, that's kind of the key thing to bifurcate into something that's an inflammatory arthropathy versus non-inflammatory arthropathy. Are there soft tissue masses or lumps like that might be present in rheumatoid nodules or gout, things like that? And any calcifications in the soft tissue. So when I'm looking at arthritis cases, these are the things that we're focused in on. And we have this as the backdrop, hopefully more of this than less. But that's basically the key background that I want you to take away. So let's take a look at some cases here, and we'll just buzz through a number of cases fairly quickly. Just a normal shoulder, just to remind you of that normal joints should have nice smooth margins along the glenoid here, for example. Humeral head, nice smooth margins. The cartilage space is this space in here, and have certain normal thicknesses that we expect to see in normal situations. So lack of degenerative change, lack of osteophytes, lack of narrowing makes us think that's normal. If we look at this example, look at this lateral elbow, it's a fairly young patient, but if you look closely, and I'll try to be careful about window leveling things here, I think hopefully you can all tell that this patient has an effusion in the elbow joint. And so anteriorly, there's this lucency that's the anterior fat pad that's kind of bulging out. Probably more importantly is this subtle lucency back here, which is the posterior fat pad. So that tells us this patient has an effusion, and the most common situation we see that in is in trauma, and this patient actually had trauma, had some minor radial neck injury. But a patient with an arthropathy might just show up with an effusion without any trauma. So that's a radiographic sign that we should look for in arthritis. Having said that, different joints are better at others than showing effusion. So the elbow is a good joint to see effusions. We can see effusions to some extent in the ankle, not so much in the shoulder, not really in the adult hip. In the pediatric hip, we can see effusions and things like that. And in the hand and wrist, we can often see joint swelling that helps tell that there's probably an effusion. So simple things to start out here. Take a look at this example. So this is kind of classic bone board 101, right? So here's a patient coming through the orthopedic clinic, and this is fairly classic manifestations of osteoarthritis, right? So on the right side here, you have kind of asymmetric narrowing of the cartilage space. See how it's thinner here than here, maybe a little bit of osteophytosis here and here. And that side's like fairly mildly degenerated. On the left side, it's quite severe, right? So there's complete loss of cartilage space, and then there's the secondary signs of osteoarthritis, including sclerosis, some subchondral lucency, in this case, fairly large geographic lucency. That's probably a large geode in the joint. Seen better here as I zoom in on this left hip and on the frog leg view. So advanced osteoarthritis in this example. The hands come through fairly frequently, and we tend to do a standardized exam where we do PA and ball catcher's views of both hands. And the key thing here is to just be systematic and look through each hand carefully for those signs of symmetry, joint space narrowing, and different degrees of arthropathy. So if we focus in on the right hand here in this patient to start out, let me just go to more proximally here. You want to look at the intercarpal joint spaces and the radiocarpal joint spaces. In this patient, they're fairly normal, kind of moving down into the MCP joints here, pretty normal, and they're fairly uniform as you go from 2 through 5 across here. As you go more distally, start to see some abnormalities, right? So this second digit is fairly normal here. This DIP joint starts to show some narrowing, small osteophytes, and these are more advanced here and here. And so we should know that when you're looking at arthritis, if it's more distal involvement without erosions, like in this, that's a pretty classic appearance for just osteoarthritis involving the hand. And that may be asymmetric in patients because of hand dominance. In this particular patient, it's fairly symmetric. The other thing this case brings up is whether there's actually an inflammatory component superimposed or the inflammatory type of osteoarthritis. And this patient, it may be the case that there's an inflammatory component. And the key thing that we look at there is whether or not there's central erosive change in the DIP joint. So for example, this left index finger here, you can kind of see this gull wing appearance. So there's some more central erosion, loss of cartilage space in that appearance that makes us bring up the possibility of the inflammatory type of osteoarthritis. And this is a little bit of an aside, but it's been traditionally taught that osteoarthritis has not got an inflammatory component, but it's becoming more widely known that, in fact, many patients with OA have some degree of inflammation. And the important thing there is that probably two things. One is they don't typically get erosions like the classic inflammatory arthropathies, but the key thing is that they can actually benefit from corticosteroid injections to treat that inflammatory component before they get some kind of definitive therapy, if there's some therapy like that available. So here's the next case, another bilateral hand examination, and if you look at this one, relatively normal appearing bilateral intercarpal, radiocarpal joint spaces, but arthropathy involving the CMC joints and wrist joints here. So if I zoom in on this right side here, and this is where you folks online, I'll be curious how the video quality is coming across. You're all muted, so if you're complaining, I'm not going to be hearing it now, but narrowing of this joint, the scaphoid, trapezium, trapezoid joint, this joint we call the STT joint without erosions, narrowing here at the first CMC joint, and then we go further distally, pretty good MCPs, PIPs, and then the DIP joints, you can see again, you should be able to see a cartilage space here, but it's narrow here, here, with little osteophytes, so that's again pretty typical for just OA of the hands. When we look at the inflammatory cases in a minute, the key thing is to be able to pick up the erosions that you'll see. But in each of these joints, you should be able to follow the cortical margin around the phalanges in each case without seeing little divots around them. So again, just simple osteoarthritis. And again, remember that this is usually more of a distal distribution than rheumatoid, which tends to spare these DIP joints. One other case here that's probably inflammatory osteoarthritis, and so there is a little bit of an imaging overlap, although the erosions in this situation are not as dramatic by any means as the true inflammatory arthropathy. So again, looks very similar to the other case I showed, but you can see that there's kind of this gull wing appearance here to this DIP joint. A lot of narrowing, looks like typical OA here. All right. Next victim here. So in this case, I think if you look at it, let me move this up a little bit. Probably some mild arthropathy involving the radiocarpal articulation here. There's some narrowing, a little bit of sclerosis. Come to these MCPs, and this is where the main arthropathy is in this patient. And it has an appearance that's fairly consistent with osteoarthritis. The key thing in a case like this is that it's really predominating in this second and third MCP joints. So hopefully you all are thinking, oh, I know what that probably is, or what the tendency is for that. The mid and distal joints are pretty good. Some of these patients get pretty severe arthropathy here with a big overhanging kind of osteophytes, and this is pretty typical for CPPD arthropathy or pyrophosphate arthropathy. And in some of these patients, you can actually see chondrocalcinosis. In other areas, you don't have to have that. This patient doesn't really have chondrocalcinosis. This patient does, though, so different patient, and we'll zoom in on the carpal bones here, and you see a really severe degree of narrowing between the radius and the scaphoid, that radioscaphoid articulation. The radiolunate articulation is in pretty good shape here, and you can see this faint calcification here, a linear area here and here. So that's along the triangular fiber cartilage, so that's consistent with chondrocalcinosis involving the triangular fiber cartilage. And this is an appearance of, anybody in the audience know? Slack wrist, Dr. Sin, thank you very much. And so slack wrist or scapholunate advanced collapse is something that occurs with deficiency of the scapholunate interosseous ligament. And what happens then is the carpal mechanics get disturbed, and it tends to lead to a progressive arthropathy that involves particularly that radioscaphoid articulation. And this example doesn't show it real well because of all the degeneration, but you may be able to see that the lunate is tipped dorsally here, and the scapholunate angle would actually be increased going along with that scapholunate dissociation. So I would say the majority of these types of slack wrists that we see are not really in the setting of CPPD, but are in the setting of traumatic scapholunate dissociation, or scapholunate ligament tear, but it's something to keep in mind that it can be associated with CPPD, and that probably causes the degeneration of that ligament and making it more prone to tear. You can see on this sunrise view of the knee, here's the lateral facet. It looks pretty narrow over here, a lot of osteophytosis. And if I go to the frontal view here, and I'll zoom in on this left side here, so there's basically severe, complete loss of cartilage space laterally. Medially, I think you can see that there's some calcification that projects in the medial joint space here. That can either be along the hyaline cartilage, actually on the bones themselves, or it could be even in the meniscus. But this is chondrocalcinosis, and we see it all the time. We often don't know exactly what the significance of it is for a particular patient. But in the knee, one of the things to keep in mind with CPPD is that it seems to have a predilection for involving the patellofemoral joint. And you can see on this lateral view that this patellofemoral joint is severely narrowed. And some patients can even get such severe arthropathy that it sort of saucerizes out the distal femur in this area. And that's something to bring up for CPPD. Now, a question comes up, does that really affect the management of these patients? And the short answer is probably not, because they end up getting arthroplasties anyway. But I've been told before that it may be that patients with CPPD actually may have a poorer outcome from their arthroplasty and may have more rapid joint wear and prosthesis failure than the patients that don't have CPPD. So moving along here, does this look reminiscent of a case that I just showed a minute ago? Again, so we have a left hand here, and if I zoom in on this a little bit, you can see the radiocarpal articulations are pretty good, and intercarpal, no obvious chondrocalcinosis. But you come to this second and third MCP with those big osteophytes again. What should that make you think of? CPPD. Okay, excellent. Okay. Pretty good distally, maybe some minor degenerative changes there. So the other thing that I mentioned at the beginning is that the patient demographics and age, so age and gender play into what we think about arthritis. And so if we said, well, this is a 75-year-old patient, we might just think, well, that's a really degenerated right knee. But if I told you this is a 25-year-old patient, then that should make us think again about that. And so in this example, the left knee is fairly normal, but the right knee has pretty severe arthropathy, like narrowing of the lateral tibiofemoral compartment, osteophytosis, and you can see on the sunrise view here, the lateral view, we can see that this is a female patient that she has fullness up in here consistent with a joint effusion or synovial thickening. And so a severe arthropathy in a 25-year-old should make you think of probably a couple of things. And what are a couple things that you might think about? Like if this was, in this case, a female patient, 25 years old. Yeah, so juvenile, let me just check this warning thing here. Okay, it's whatever. Hopefully we're still online there. So juvenile chronic arthritis, and that may be an asymmetric distribution, and you can see that her opposite knee was relatively spared here. The other thing to think about in a young male patient could be something like hemophilia. That tends to be more likely to be symmetric because of repeated hemarthroses. Or it could be that the patient had some sort of insult to this knee in the past, like they had an infection that caused cartilage degeneration and then developed some secondary osteoarthritis type appearance. So again, the key points are that you have to take advantage of whatever clinical information and patient age we have to help make the diagnosis. And goodness knows that the requisitions for these exams usually say knee, AP, and lateral, ASAP. They don't really give us any useful information. So here's a patient who is a little bit older. She's probably 50 something. That's actually quite young, actually, now that I think about it. But you can see that there's quite a bit of fullness involving this elbow joint. All that soft tissue opacity there. That's probably the anterior fat there. Posterior fat pads bulged out here. So there's a pretty significant effusion in this joint. And if you look at the joint a little bit more closely here, I think you can see that there's maybe a little bit of osteopenia. There's kind of some sharp margins, and things just don't look quite right as far as the spaces between the radius and the ulna here. So she's developing an arthropathy with a large effusion. So that could be a variety of different things, but the presence of the large effusion should make you think of something that could be inflammatory. And the main reason I show this case is because I want to show the follow-up about a year later, where it went from reasonable looking ends of the bone to this really bad looking elbow joint, where you can see um, a lot of lucency in the subchondral bone. The whole radial head looks like it's eroded away here, right? It should be way up here on the ulna as well. So give me an example of something that in a 50-year-old patient without infection could give you this degree of arthropathy that's progressive over the course of a year. Yeah, rheumatoid arthritis. And so this is actually a pretty good example of that, where pretty aggressive, if you will, rheumatoid arthritis with pannus and cartilage destruction. And once the cartilage is destroyed, then that pannus just goes and kind of continues to erode away the bone. So it can progress pretty quickly. Now, clinically, that may be a fairly obvious diagnosis because they may have arthritis in other areas of the body. And the other, thing to keep in mind is that these things like rheumatoid and psoriasis, these are systemic disorders, right? So they tend to be distributed throughout the skeleton and in a fairly symmetric pattern. So that's that's an important kind of backdrop point. So rheumatoid arthritis progressing really quite rapidly. Another example of rheumatoid here. So usually when we see cases that are this bad, the odds are statistically, if you will, that there's a lot more patients out there with rheumatoid arthritis than with most other inflammatory arthropathies. So, and they can still progress despite somewhat improved drug therapy and so on. They can still progress to where there's really like nearly destructive change, severe narrowing, and kind of malalignments that can occur. And it's difficult to make that diagnosis when you have this advanced of a stage, because typically they'll get some secondary osteoarthritic type changes as well that makes it difficult to tell. So you're kind of banking on statistics, but this patient has a nice example of erosions as well. So if I really zoom in on this fourth MCP joint here, you can see on this ulnar aspect, there's nice cortical bone along here. Here's the MCP, and there's a bite taken out of there. That's like a big erosion right there. And there's probably an erosion right here as well, an erosion there. So those are things you just shouldn't see in osteoarthritis or the non-inflammatory ones, and that would include, you shouldn't see this in inflammatory OA. The other key thing with rheumatoid that we kind of hopefully harp on over and over is that the distribution is such that you get severe carpal involvement and intercarpal involvement and MCP, PIP involvement. Like here's an erosion here in this, but the DIPs are virtually always spared. And so here, if we look at these DIPs, they actually look pretty normal. So one of the first things your eye should do if you see an arthritis case and you see erosions is you should go from proximal and then look immediately at the DIP joints. And if the DIP joints are normal, think strongly about rheumatoid. If the DIP joints show erosions, you can almost throw rheumatoid out the window and not even consider that diagnosis. So when you're in the inflammatory category, that's like the most important distinction of anything, I think, is to look for the distal joint involvement. Here's another case that's fairly advanced, right? And again, the goal this morning is just to go through a whole bunch of examples to show you different kind of appearances, and hopefully some of this will kind of sink in. So here there's a lot of malalignments and probably dislocations at these MCP joints. The fingers are all splayed out, and this could be a couple of different things. It turns out this is actually a patient with severe rheumatoid arthritis, as best they can tell clinically. Doesn't have a whole lot of involvement in the carpal bones or radiocarpal, but this MCP involvement can lead to really severe deformities over time. And again, rheumatoid being common, that's a common thing. The other thing you could think about in a case like this would be lupus and connective tissue disorders and the kind of malalignments that you can get in lupus. And sometimes these patients have an overlap type syndrome or sort of a mixed connective tissue disorder, and even the immunologists don't always nail down a specific diagnosis for these types of patients. But we can help somewhat by looking at the distribution pattern. Okay, so let's take a look at this case. So a little bit different, fairly young patient, about 35. And let me just zoom in on this right hand here. And let's take a look at the carpal bones, looking good, intercarpal spaces, go down to the MCP joints here. These look fairly normal, right? Maybe a little bit narrow, but this doesn't look very normal. So if we look at that MCP, again, you should be able to follow cortical bone all the way around. And on this radial aspect, you see a little bite out of there. Now, if that was the only finding in this case, I wouldn't be totally sure if this is an inflammation or not, or an erosion. So you kind of have to look elsewhere on the exam to see what else is happening. So if I just zoom back down on this one for a second, one thing you can see is that the second digit is really swollen up compared to the others, right? It's very pudgy, like sausage-like looking digit, right? And that sausage term should ring a bell as far as one of the kind of Aunt Minnie diagnoses in radiology for what arthropathy are we thinking about if you say sausage digit? Yeah, psoriatic arthritis. And so that's an inflammatory arthritis. And so in this patient, what I'm thinking is, well, that looks pretty abnormal, and it looks like it's inflammatory. The reason being that, the margins of the bone are really irregular there, and that's compatible with erosive change. This digit, it's hard to tell. It almost looks like it could be fused there, which could be a clue. But you'd also perhaps think in this patient, boy, do they have some kind of infection brewing in there? Could that be a septic joint? And so what you'd want to do is you want to look elsewhere on the patient's exam to see if there's other clues. And so on this hand, there's really no other major clues. It looks pretty normal. But I think this is the case. If we go to the opposite hand, look at this fourth DIP joint. Irregular margins, maybe a little osteophytes, but DIP joint involvement, it's fairly asymmetric to the other side in the sense that not all DIPs are involved. And that's another thing about psoriatic, is that even though it's a systemic disorder, it tends to be a little more scattershot in its attack of the joints. So again, going back to the basic principles, here's a patient that could come into the clinic with this, or maybe they've been followed in dermatology for psoriasis. And so then, okay, this fits with psoriatic arthritis. One other point about psoriatic is that it's important to know that a certain fraction of patients that's not insignificant, maybe 15% or so, if I'm remembering right, can actually show up with the arthritis before the rash. So if someone has this type of an arthropathy, it's reasonable to raise that possibility even if they don't have a rash. A lot of times the findings are subtle or they're mixed, and we say, we don't know, this patient's got all kinds of different things. So here's an example. Older patient, you can tell they're somewhat osteopenic here. There's the usual first CMC, osteoarthritis. It's often on both sides, usually worse on the dominant side. And the question that comes up is, do they actually have something else besides that? Is it just OA, or is it something that's inflammatory. And this gets to the subtlety of these cases. So if we look at this left hand and come to the MCP joints, pretty good, right? There's a little bit of lucency here, not a definite erosion. MCP, PIP joints, that looks like a joint that's got osteoarthritis. And you got to keep in mind that a lot of patients will like damage joints, have trauma that could cause that appearance. I know personally I hit my finger with a hammer many times, and that joint's probably going to get osteoarthritis. I will add in that thread that I do a lot of hammering, so it's like a few hits over millions of hammer throws, not like one or two uses of the hammer. So statistically, I'm actually pretty good at it. But so what about this joint here? So we know we have got OA, maybe some post-traumatic change, but here in this fourth DIP joint, there's that little bite right there. And that we can't really explain with osteoarthritis. So that's suspicious for an erosion. And maybe there's another one right there. So all of a sudden, this subtle finding here takes this patient from having, yeah, they have OA, but they probably also have some sort of an inflammatory arthropathy component. And so if we see that, then that kind of triggers the clinicians to think, oh boy, maybe I better check a rheumatoid factor, SED rate, mitochondrial count, whatever all the stuff is that they do for that to kind of work it up more. So again, as I started out saying, these arthritis cases, they are very subtle, and you have to look for these subtle type findings. And admittedly, we're not always black and white about our diagnosis. We may end up saying possible erosion, raising the possibility of an inflammatory component, and then rely on the clinical information to help make the diagnosis more firm. Sometimes it requires a joint aspiration, usually done in the clinic, possibly looking for crystals, possibly looking for other signs of infection or inflammatory markers. One other thing on the inflammatory side of things, so we see a lot of feet, and we love them, and a lot of these plantar enthesophytes here, so plantar calcaneal enthesophyte. In this patient, they also have a prominence of the calcaneal tuberosity. It's rather sharp in here. And the arthritis that kind of goes hand in hand with psoriasis, if you will, it's pretty similar, is now called reactive arthritis. It used to be called Reiter syndrome, but it's no longer called that. And so it sounds like kind of a generic term, but it's one of the seronegative spondyloarthropathies, and it, compared to psoriasis, probably has a little more tendency to involve the foot, and especially regions like the retrocalcaneal bursa in here. And it can cause erosions, which this patient maybe has a little bit of patchy lucency in here, not very discrete erosions. It can also erode this plantar enthesophyte here. So if we see that in the right setting, we can raise the possibility of reactive arthritis. And that has a syndrome that goes with it too. It may have the, I think, uveitis or iritis and urethritis, for example. So some other kind of protean clinical manifestations that can make you think of reactive arthritis. I don't have a lot of great examples of that. Moving on here. So we looked at a number of cases of rheumatoid and a couple of other like psoriasis and so forth. Take a look at this patient. And so we have our arthritis examination here, bilateral hands. This one's a little bit hard to window level. But you can see it's clearly quite abnormal, right? And one of the things you should notice if I window for soft tissues, all these lumps, right? All these soft tissue prominences. And what that makes me immediately think of two things. One is, could they be rheumatoid nodules? But the other thing is, how about gout, right? Because you get gouty tophi. So gout is another thing that's inflammatory. It's not infectious, but it's a crystal arthropathy, right? And we talk about the kind of protein manifestations of that. And let's see, if we look at this, look at the right hand in more detail here. This fifth MCP has kind of classic findings of gout, where actually the joint space is fairly well preserved, isn't it? Here and here. But look at this big lucency right there with this edge that sort of overhangs, right? The overhanging edge, that's a classic manifestation of gout. And the erosions tend to be more non-marginal. They're not right at the edge of the articulation. They tend to be a little bit further along the capsule here. So that's a pretty typical appearance of gout. And it may be scattered around, like you see different joints here with different focal lucencies that are consistent with erosions. If you just had this one joint here, you might think of something like psoriasis, but that wouldn't fit with the soft tissue masses and all the other prominent erosions that are scattered around here. And again, you can have some overlap in things, but this patient had pretty advanced gout, bilateral involvement, and usually that clinical diagnosis is fairly evident. So again, here's big erosion into this MCP joint and so on. So that's where you get, uric acid levels and stuff like that. Another example of gout here, and again, just seeing the pretty focal erosions here. In this case, the fifth metacarpal, DIP joint here, and then here you can see again, should see nice cortical margins, erosion there, that erosion there, and a lot of soft tissue swelling. Nice example of overhanging edge type thing right there. All right, so kind of hopefully you're all following along okay here. One more example of gout. Okay, this is the classic kind of podagra thing, right? This is like, as Dr. Jeffrey would say, this is like the state fair champ of gout. But this patient has a huge mass. They came in with a complaint that their shoes no longer fit or something obvious like that. That's a joke. Big soft tissue mass here, erosive change there, a lot of irregularity. They also have it in the region of the fifth MTP joint. Some of these tophi will calcify, like in this patient. Often they don't. I don't know the exact frequency of that, but the classic podagra, first MTP pain with a red swollen toe that looks inflamed or possibly infected, correlates often with gout. And the good news is medicine is improved in some areas, and so patients are showing up earlier with their gout, so they get treated earlier, and so we don't see these advanced manifestations that often, except in patients who have gout that's really not responding to therapy, or they don't have good medical care, or some other reasons that they may have some, more advanced metabolic disorder that just makes the gout that much more kind of aggressive. So we're getting close to 8:15 here. We'll kind of wrap up in just a couple minutes, but I'll show you a few more cases. So the other thing that can come up, soft tissue calcifications, right? So if we look at this patient's hand, the joints actually look fairly good, but there's these blobs of calcification in a few different areas here. And I got to admit, I can't keep a very long differential diagnosis list in my mind of soft tissue calcifications. But things to think about, just think about connective tissue disorders broadly. And so things that cause calcification like scleroderma, dermatomyositis. You can have dense material in the soft tissues from iatrogenic, well, not really iatrogenic, but sort of traumatic reasons too, like the classic one is like a paint gun injury where somebody injects paint into their digit or something like that. That's not that common, hopefully. But this is an example I got from Kate of scleroderma. And along those lines, the connective tissue things that you kind of can think of those as having some vascular insufficiency issues, like in scleroderma, the patients get all kinds of vascular problems as well, is to look for erosion of the terminal tufts. And so this patient has fairly normal tufts in here. And the tufts kind of have a shovel-like or a spade-like configuration. They go out and they kind of fan out. Should have a little bit of an irregular cortical margin along there, but it should be fairly smooth. So compare that one with I think the next patient here, the second to the next patient. This is just a different example of that same digit there with scleroderma. So we can get to the one with the. Here's another example actually, and I'll show the erosive of the tuft in just a second. But look at the extensive calcifications in this patient. So this is an example of a patient who has not only these soft tissue calcifications, but a lot of arthropathy here, right? Because you can see like this left second digit, this proximal phalanx really tapers. There's a lot of density in there. Really don't see the joints hardly at all. Now, the things that can cause these kind of really progressive and destructive arthropathies are not that many things. It's good to think about psoriasis in that setting, because that can lead to really pretty severe like arthritis mutilans, and occasionally rheumatoid, but rheumatoid usually doesn't cause that extent of bone erosion. So this patient actually had scleroderma, but they also probably had psoriatic arthritis that was superimposed or concurrent, leading to that degree of arthropathy. So this is the example I was thinking of, where if you look at the terminal phalanges here, this one is pretty normal. That one's eroded, right? Flattened out. And then this one's eroded and kind of flattened out as well. So that's acro-osteolysis. And again, there's a whole list, a long differential diagnosis that includes random things like polyvinyl chloride exposure and things, and you can look that up. But just think of connective tissue disorders like scleroderma, Raynaud syndrome, Crest syndrome, things like that. Ankles, so different patient, and kind of maybe one or two last cases here. Bilateral ankles imaged on one image here, and you can see there's obviously a lot going on in this left ankle, right? And it may be that this is an ER patient, they came in with ankle pain, but you just think, boy, that would be a really nasty fracture to occur. So when you see this degree of kind of disorganization, bone fragments here, a lot of soft tissue swelling, in a patient may or may not have even that much pain, what should that make you think of? Let's say the patient was diabetic. Yeah, Charcot joint or neuropathic joint. And they get like the 5 Ds, like density, destruction, debris. I can never remember doctor's bills, diabetes, but they lose sensation, and so they can have trauma repeatedly to these joints. They have vascular issues as well, and it can lead to a really severe arthropathy that can involve many joints. A lot of times it's ankle and foot. This patient also has involvement of the midfoot, and it's a little bit hard to see here, but there's arthropathy involvement here, and the foot's kind of collapsed down, so both the ankle and the foot. So virtually always those patients are going to have diabetes. They might have something random, like sometimes a syrinx or congenital insensitivity to pain that leads to this type of insensate predilection for arthropathy. Why don't we have this be the last case? We'll just wrap up here. And so another kind of bone board case coming through, right? So bilateral hips, and we can tell that the hips are abnormal, certainly on the right side, possibly on the left side as well. So, but what do we see here? Well, the joint itself, there's still some preservation of the cartilage space here. Let me see if I have a zoomed in image of that. But the key thing in this example is that we've lost the normal contour of the femoral head. So the left side is pretty nice and round here. There's some patchy sclerosis there. That's about the only abnormal finding. But the right side has lucency and some sclerosis, but this line of subchondral lucency there and lack of the sort of normal sphericity of the femoral head. So that's like a subchondral fracture, right? So what this is like an ant mini. You should see this and say, oh, why does this patient have AVN, right? Avascular necrosis. And if we look at the frog leg lateral view here, this is a really helpful view in many cases because on a normal frog leg lateral, again, you should see a nice normal round femoral head, except for the fovea, which can be a little notch in here. But in this example, you can see the femoral head comes up here and then it kind of takes a dip down and then it's kind of irregular. And this crescentic low intensity line here, radiolucent line, that's the area where the bone has fractured and it's starting to collapse down there. So it can be bilateral, and usually, again, there's the clinical manifestations. You try to figure out, oh, why does this patient have AVN? And I'd say in our population around here, the most common things are patients who've had corticosteroid use for whatever reason, and a lot of our patients around here have had high-dose corticosteroids because they had leukemia or some other malignancy that was treated with corticosteroids. Okay, so let me just go back to the this slide that I started out with here and just kind of re-emphasize that, you know, there's the clinical world, which we can tap into a little bit with EPIC if we can find notes on patients. That the important thing for arthritis, and the more we know about that, the better we're going to be as far as accuracy. And so then we have a big role to play in looking at where the arthropathy is distributed, this sort of specific local distribution, that business I mentioned about the DIP joints being spared and rheumatoid, swelling, effusions, cartilage spaces. The key thing about finding erosions or no erosions. Sometimes soft tissue masses help and calcifications can help us as well. So, so that's a little tour of a bunch of cases, and I will stop there and take any questions offline here. But I hope it was helpful in kind of trying to reinforce some of the things that Dr. Stevens showed a couple of weeks ago. And thanks so much for your attention.